Well, dear colleagues, good morning or good evening according to your time zone. First of all, let me thank the Dental Tribune Study Club and the GC Campus for this prestigious invitation. And let me give you the greetings of the University Federico II of Napoli and of the University of Siena, where I teach as a research professor of prosthodontics and digital dentistry. I was requested to give an update about dental cementation and the selection of luting agents according to restorative materials. And I found this topic really challenging, as in the last decade, improvements in dental materials technology have dramatically changed the approach to cementation, and this is considered a hot topic in scientific literature as well. Here you can see the overview of this lecture. The topic is really wide. It is not easy to sum it up in 45 minutes. So we will go through the properties of dental substrate and the restorative materials, the adhesive characteristics of the luting agents, the surface treatments of dental ceramics, till the clinical procedures that should guide practitioners in the selection of the most proper cement. When talking about cementation, the first question usually asked is how to cement, but according to my opinion, the most important consideration should be where to cement. In fact, the substrates we have to work with are very different for both biologic and mechanical properties, and the proper comprehension of how to manage them and condition the surfaces is the first undebatable step toward the clinical success. Moreover, the proper selection of luting agents has to consider what we have to cement and consequently how we have to treat the surfaces of dental materials before cementation. For example, metal ceramics and old ceramics are completely different in terms of optical properties, but zirconia, for example, is a ceramic oxide of metal, and this is significantly important for its cementation. Conversely, the approach changes with glassy materials, just like the feldspathic ceramics, that are very appealing from an aesthetical point of view, but less tough, and so they need an active cementation to create adhesive monoblocks, just like silicates and disilicates, whose wrong management on the basis of presumed fascials of the moment could cause clinical failures, particularly in posterior areas. Furthermore, nowadays it seems that cementation is almost a synonym of adhesion, but auto-adhesive procedures can be useful in the presence of unfavorable preparation geometries, just like in the smaller. A conventional cementation approach still represents the first choice when preparations are retentive, and the characteristic of the restorative materials allow for such an approach. So let's go through the properties of dental substrate first of all. The knowledge of the intrinsic characteristics of dental tissues and the understanding of their adhesive properties is very paramount to select properly the correct cementation technique, and in any case, the preservation of the maximum amount of tooth structure is always mandatory. It is well known that enamel is a predominantly inorganic mineral tissue, very hard and wear resistant, but likewise brittle and not reactive, so ineffective in regenerating over time. On the contrary, dentin can be considered a biologic composite tissue with a higher amount of organic components, and it is porous and very elastic, and it can regenerate, so responding to external stimuli and modifying its structure over time, changing into reaction or sclerotic dentin, so completely different substrates. And finally, dental cementum, a tissue with intermediate properties, porous just like dentin, but scarcely elastic and not regenerable as enamel. The most important tissues regarding cementum, however, are represented by the permeability due to the continuous contact with periodontal fluids and its elastic discontinuity that amplifies stresses and strains, particularly the cervical margins, and significantly influences the longevity of adhesives and luting agents. Now, let's move to some brief data about adhesion and the biomodification of tooth structures. This is a crucial prerequisite for the selection of proper luting agents. The techniques of chemical conditioning of dental substrates were developed in about 1950 with the acid etching of enamel. Then there was the introduction of polycarboxylate cements, resin composites, and glass ionomer cements, showing the first attempts to achieve an active adhesion to dental tissues. Finally, dentin bonding revolutionized the market till the most recent introduction of complex chemistry components, just like self-adhesive and universal adhesive systems. Considering that the range of clinical acceptability for adhesion is about 70-90 megapascal, it is worth noticing how older generation adhesives were much more effective on enamel. Time passed, the clinical procedures have been improved, but most practitioners still believe in this conviction. But today, the most recent adhesive systems are really performing even on dentin. Although the less satisfactory clinical results have to be referred to the more difficult management of adhesion on dentin and to the more complex control of intrinsic moisture. We all know that the dental market is crowded with different adhesive systems with a strong trend towards simplification, from the traditional three-step etch and rinse materials to bi-component prime and bond or etch and prime agents, till the so-called all-in-one systems in which the etchant, the primer, and the bonding are diluted in the same solution and have to act more or less at the same time. The three-step adhesives are the only to be used on dry substrates, whereas the simplified systems have to be applied onto wet tissues, particularly on dentin. But how wet? To date, no research stated clinically objective criteria to understand how shiny or how glossy the dental surface has to be prior to adhesive rubbing. So simplified systems are actually easier to be used, but contrary to marketing advertisements, are operator sensitive and at the same time indeed. Moreover, it is worth remembering that the hydrophilicity of dental adhesives is related to their acidity, at least during the setting time, and that three-step systems are more stable as regards marginal microleakage and staining, so they should be preferred on enamel and anterior teeth. Recently, in 2011, a new class adhesive was introduced in the market, the universal or multi-mode adhesives, that were designed as all-in-one systems, but with the innovation to be used with etch and rinse, self-etch, or selective enamel etching techniques, so being very versatile materials. Consequently, the practitioners can decide on a specific adhesive protocol according to the clinical conditions and can adopt the simple solution of each technique. There are several universal adhesives available on the market, but most innovative and captivating, just like the G-Premio Bond from GC, for example, are provided with different functional monomers and dual cure activators to be used with all kinds of restorative materials. Sorry. If we look at the most recent literature regarding universal adhesives, it is clear that their bonding effectiveness is enough for clinical use, that the use of selective enamel etching can be useful to increase the long-term durability of the adhesive complex, that the bond strength of multi-mode adhesives is dependent on the brand and it can be increased with prolonged emblowing up to 30 seconds to make the layer of bonding thin and uniform, and that universal adhesives have shown promising results, but their clinical behavior has to be better studied and understood. So briefly, we can classify the adhesive strategies in three groups. The etch and rinse is related to the use of the classical three-step adhesive. The self-etch is characterized by the use of different two- or one-step simplified systems, while universal adhesives need only one solution that can be used as a self-etch adhesive or can be anticipated by the application of an etchant in the etch and rinse mode, and you can also select the total etch or selective enamel etching as well. The main difference between the total etch and the self-etch techniques relies on the presence and use, particularly of the smear layer. In the total etch approach, the surface debris have to be completely removed, making interprismatic enamel and dentinal tubules available for resin infiltration. Conversely, the self-etch technique works on the modification of the smear layer, not on its removal, and it becomes a semi-permeable, crucial component of the combined almost simultaneous action of etchant, primer, and bond. In conclusion, the success of adhesion is based on the comprehensive knowledge of the biological and mechanical properties of substrates, and it significantly influences the tube preparation, the selection of restorative materials, and the choice of cementation techniques as well. Now, let's go through the characteristics of different dental cements. We all know that cementation has to guarantee retention of prosthesis, marginal seal, and longevity of restoration. Or in other words, cementation baseline represents the first step towards clinical success over time. The properties of an ideal luting agent are definitely clear: absence of sensitivity, effective seal, easy handling, no aesthetic interferences, minimal thickness, and radiopathy. Probably, in my opinion, just the strong bond should be considered a useful option, but not a basic prerequisite, at least in the presence of retentive geometries. However, the adhesive procedures are crucial in using glassy ceramics, for example. In this case, the pair metal-free adhesion allows for a significant reduction of dental tissues removal, performing very conservative treatments. Nonetheless, an adhesive approach is more operator sensitive and more time consuming than traditional cementation techniques. Schematically, it is possible to classify dental cements in traditional water-based luting agents, just like zinc-containing, polycarboxylate, and glass ionomer cements. Then we have the more recent monomer-based cements, just like total etch and self-etch luting agents, and hybrid cements, a class with intermediate characteristics, such as the resin-modified glass ionomer cements. Moreover, as regards bond strength, it is also possible to classify these luting agents in low adhesion, medium adhesion, and high adhesion. As a consequence, on the basis of the different characteristics of mechanical interlocking and active adhesion to dental substrates and restorative materials, it is possible clearly to state that all cements are potentially adhesive according to the intrinsic chemical properties. Now let's analyze briefly the properties of different types of luting agents, starting with zinc oxide cements that can contain or not eugenol and are traditionally used as temporary cements. They are characterized by micromechanical bonding, moderate retentiveness, and are indicated for all interim restoration. They are cheap and very user-friendly, but very soluble at the same time and not stable over time. Their remnants, particularly those containing eugenol, can interfere with the adhesive procedures. Zinc phosphate cements are the reference gold standard in the literature since they have been used for more than a century. They present an acid-base reaction and are mainly indicated for metal-based restorations, including polycrystalline ceramics. They are easy to use and pretty retentive as they are not very soluble in the oral cavity. However, they are characterized by very acid pH in the first 48 hours after cementation, and so this can result in post-operative sensitivity and possible pulpal injury as well. Zinc polycarbosylate cements were the first to present an active chemical adhesion to dental surfaces with almost the same indication as zinc phosphate. They are very effective in traction, but not as much in compression. And as a consequence, they are not very used by practitioners due to high solubility, difficult excess removal, and reduced resistance to occlusal loads, showing an increased risk of marginal creep. Glass ionomer cements are very versatile materials that became popular because of their active adhesion to dental tissues and fluoride release, attesting very good biocompatibility. Their clinical history has been successful for decades, and the bond strength can be superior to that of some dental adhesives. Their solubility is compensated by an ionic exchange over time, but similar to polycarboxylate materials, they can cause post-cementation sensitivity and can show brittle cohesive fractures at margins as well. The resin-modified glass ionomer cements or hybrid cements were the first eluting agents to show a monomer polymerization reaction, widening their indication to all ceramic materials as well. They present intermediate properties between GICs and resin cements, are really versatile, and show the simplified single-step adhesion for the first time. However, the removal of cement remnants is not very easy, and they are negatively affected by water absorption, potentially leading to marginal leakage. Finally, the more recent resin cements, purely characterized by a polymerization reaction, their clinical indication cover almost all kinds of restorations, and they are very versatile in terms of adhesive strategy and curing mode. The main advantages are excellent aesthetics, very good retention, and easy handling. However, they also show some drawbacks, such as high cost, difficult excess removal, and nano-leakage over time. The latest resin cements introduced in the market were the self-adhesive that can be schematically divided into single component and assisted due to the possible need of primers or chemical activators onto dental tissues, restorative materials, or both of them. These two classes present optimal aesthetic properties and satisfactory retention, although the long-term bond strength of total etch cements is still superior. Self-adhesive cements are claimed as very easy handling materials due to a simplified adhesive approach. Nonetheless, their long-term behavior has to be completely understood yet. As reported in this interesting review by the University of Siena, contrary to common sense, self-adhesive cements present better performances on dentin than on enamel, because of the necessity of a certain amount of substrate moisture, as we have previously mentioned. Although their effectiveness is satisfactory for clinical use, the absolute values of bond strength are inferior to the and risk of marginal discoloration is higher than the total etch systems. So this very recent review of the literature pointed out that self-adhesive cements are gaining popularity because they are really easy to be used. Their clinical performances, at least in the short term, as literature data are not so long right now, are comparable to those of traditional cements, but further clinical studies are necessary to draw definitive conclusions. Now, let's discuss some topics about the clinical procedures, starting from temporary cementation. As we have seen, the remnants of provisional eluting agents interfere with the final cementation, particularly if you go for adhesive strategies, and have to be completely removed, better with alumina particle abrasion. Moreover, the use of chlorhexidine can lower the final bond strength, so glutaraldehyde should be preferred as cleansing agent, desensitizer, and adhesion enhancer as well. Substrate surfaces have to be cleaned before final cementation, and not only blood and saliva have to be considered contaminants, but also silicone disclosing materials and particle debris. And water and acetone are not useful to remove the remnants, whereas a mild application of cleaning pasties or phosphoric acid proved to be effective to get this aid. As to retention, I suggest who was interested to read this very updated review. It can be schematically stated that the retentiveness of eluting agents progressively increases from water-based to resin cements because of the addition of chemical to micromechanical bonding. However, on the contrary, the removal of cement remnants is inversely related to the retentive effectiveness of the materials. Particularly, self-adhesive cements have to be carefully used, and side areas have to be properly protected to avoid the undesired adhesion to the adjacent surfaces. And all eluting agents are potentially toxic because of their chemical composition, of course. Particularly, the resin cements can release unreacted monomers, while the polycarboxylate materials can corrode titanium implant components, as you can see in this picture. Differently, the zinc-containing cements present useful antibacterial properties and can be useful if you have deep preparation next to the pulpal tissues. The cement excess entangled in soft tissues can remain asymptomatic for years or can cause severe inflammation, particularly around dental implants. Nonetheless, the cement lac can create marginal gaps with subsequent bacterial colonization and phlogosis as well. Consequently, the cementation margins have to be carefully inspected always and preferably under magnification. Moreover, low viscosity luting agents, deep preparation margins, and undercuts might increase the risk of trapping cement remnants within soft tissues. And the cement excesses have to be removed with plastic instruments just like Teflon or urethane dimethacrylate in order to avoid the scratches that would increase surface roughness and bacterial colonization. Thus, metal instruments should be avoided at all. Unfortunately, there are no guidelines about the ideal amount of cement to be put inside the restoration. Of course, cement lac could cause loss of retention and marginal leakage, whereas a surplus could determine incomplete seating, difficult remnant removal, and tissue phlogosis. So expertise and good sense have to guide the clinician in quantifying the amount of cement. On natural teeth, the cement removal is pretty easy in the presence of supragingival margins, just like in the zirconia bridge on your left side, whereas it requires careful attention, dedicated plastic instruments, and I repeat, magnification in case of juxta or subgingival margins. Similarly, on implants, if the operator chooses the cemented retention, the flush prosthetic margins can be easily inspected, just like on the left side, whereas deep transmucosal paths on the right side can be affected by severe inflammation, such as the fistula on this transmucosal path caused by the tiny temporary cement remnants indicated by the arrows. In these cases, it is useful to move the cementation margin coronally by means of CAD/CAM customized abutments, in this case a zirconia abutment, placing the prosthetic margin no deeper than 2 millimeters under the soft tissues, so as to facilitate cement removal and achieving satisfactory. Radiopacity is a useful parameter as well to easily identify cement excess. Obviously, the metal-containing luting agents are more radiopaque, whereas aesthetic cements are more radiolucent. However, nowadays, most manufacturers add radiopaque components in translucent cements as well to better visualize restorative margins of aesthetic restorations, just like these ceramic veneers, for example, whose margins have been correctly sealed. Conversely, in the case of metal restorations, such as the molar crown on the right side, only cement excess can be checked, whilst the metal margins are always more radiopaque than luting agents. It is worth noticing that the cement film usually used in laboratory studies and in manufacturers' quality controls is 5 to 10 times thicker than it is used clinically. This is very important because there could be a radiopacity mismatch between the technical specification of the cement and real clinical performance. As regards implant-supported restorations, recent systematic reviews of the literature have reported higher rates of biological and technical drawbacks on cemented rather than screw-retained prosthesis. However, no specifications were given about the cement type. This is a big missing point. Today, it is not possible to draw conclusive evidence-based indications about what luting cement should be used on two implants to limit the clinical drawbacks. As to tissues, dental ceramics can be conditioned with surface treatments as well in order to improve the clinical effectiveness and longevity of the cementation. However, the acid etching technique can be used only with glass materials, but not with the high-strength polycrystalline ceramics, since the latter contains less than 5% in weight of silica particles. Thus, zirconia is acid resistant, insensitive to the etching silane bonding technique, and cannot take full advantage from adhesive procedures. A few years ago, my research group, together with Professor Fernando Zarora and Professor Marco Ferrari, published this study about the acid etching of different materials. And particularly, we compared feldspathic and zirconia ceramics, subjecting the samples to a very aggressive etching with 40% hydrofluoric acid for 2 minutes. And as you can appreciate in the SEM images, the feldspathic ceramics showed evident cavitation, very useful for resin bonding infiltration, whereas no significant modifications of the surface were noticed onto zirconia. As a consequence, we concluded that zirconia was not susceptible to acid etching, that chemical compatible cement have to be chosen, and that material was not suitable for purely adhesive restorations, just like veneers and onlays. Thus, due to its metallic nature, zirconia can be cemented using traditional water-based luting agents, just like GICs and hybrid materials. Resin cements, on the contrary, can be useful in case of poorly retentive preparations and short clinical crowns, or to seal minor surface defects due to CAD-CAM machining, particularly in case of herb machining of fluorescent zirconia blends. Several surface treatments for zirconia were described in the literature, from aeroabrasion to tribochemical treatments, from grinding to plasma spraying, from metal prizer to even laser treatments. But data are not conclusive and the indications still remain controversial. So, the evidence-based data today available state that addition onto high-strength ceramics is still discussed and less reliable than onto glassy ceramics, that no consensus has been found about the ideal surface conditioning, but most authors agree about the combination of mechanical and chemical treatments. And finally, further laboratory and clinical long-term studies are necessary to draw clinical recommendations about long-term addition onto zircon. We've talked about the conditioning of dental substrate and pretreatment of ceramics. Now let's see how to avoid the surface contamination during the clinical procedures of cementation. This is Ricardo, a very young patient who was not satisfied with the shape and diastemature of his upper front teeth that were particularly evident while smiling. On the basis of the aesthetic analysis, it is pretty evident that the gingival margins of the central incisor were too coronal, altering the interdental proportions and making these teeth look short, asymmetric, and squared. In these cases, the passive eruption is a common clinical evidence, allowing for a simple gingivoplasty. So, as the patient was not interested in treating the canines, my prosthetic proposal was a conservative crown lengthening of the central incisors without interfering with the bone, and 4 lithium disilicate veneers in order to close and better distribute the spaces. In this slide, you can appreciate the patient before and after crown lengthening, precisely 3 weeks after the intervention, to set a good dominance of the central incisors. After tissue healing, I went through a mock-up guided preparation of the front teeth in order to keep as much dental tissue as possible, accordingly to a completely minimally invasive approach. Then, digital impressions of teeth preparation and intra-arch bite registrations were recorded with an intraoral scanner in order to perform a full digital workflow. Finally, after the soft tissues had completely recovered from preparation injuries, the patient was ready for cementation. And of course, healthy gingiva are the crucial prerequisite to perform proper adhesive cementations. Lithium disilicate, as we've mentioned, can be etched with 5% hydrofluoric acid for 20 seconds. Then the entire surfaces have to be thoroughly cleaned with an ethanol degreasing ultrasonic bath for 1 minute. And finally, it is possible to apply a coupling agent just like a silane to enhance the adhesion. As we are on front maxillary teeth and the veneers are made up of a glass ceramics, lithium disilicate, my choice was a total etch approach with a universal adhesive resin cement, namely the GSM Link Force from GC that according to me is a very versatile product. Consequently, the use of the rubber dam to isolate the operative field and prevent surface contamination was mandatory, as it was a standard clinical situation. However, we will discuss a few exceptions about rubber dam shortly. I always use very thin retraction cords to prevent the entanglement of resin remnants under the gingivas, and cementation is always a little bloody for soft tissues, but this is just an acute injury, and waiting for a while, an optimal healing can be obtained with good aesthetics and integration of the restorations. These veneers were fabricated by Mr. Vincenzo Mutone with GC Initial Lisi Press. This material is characterized by excellent translucency, giving a really natural tooth-like appearance to restorations. But although aesthetics is very important for patients, I'm a prosthodontist, and for me clinical success means proper occlusal functions, just like in this case, and optimal biointegration of the prosthesis, as evidenced by the healthy condition of these gingivas under the stereo microscope, confirming that cementation was performed correctly and did not interfere with biology at all. And this is Riccardo before and after the treatment, finally satisfied to show his smile. This case was useful to show the up-to-date gold standard of adhesive cementation, but clinically the cementation techniques are different according to the clinical needs and the type of luting agent. So we can distinguish low micromechanical adhesion using traditional water-based cements, medium chemical adhesion by means of self-adhesive and resin-modified glass ionomer cements, and purely high adhesion using total etch resin cements. Of course, different luting agents necessitate different isolation approaches. No dam is mandatory needed for water-based materials. Moisture control by means of different isolation aids is required for simplified adhesive systems, while the rubber dam should always be being used with total etch cements. In fact, we all know that moisture and contaminants control is mandatory in all oral regions to achieve the best adhesion, particularly for restorations without primary retention, just like anterior veneers or posterior onlays. However, more than half of dentists do not use the rubber dam even for adhesive techniques. Is it unbelievable? It is not, since as you can see these are very recent data obtained from questionnaires collected in the United States. Notwithstanding, in my opinion, a poorly placed rubber dam is less effective than a proper control of the operative field. So in selected and non-standard, this is very important, clinical conditions, with or without rubber dam, it is possible to apply for isolation aids as partial dams, retraction cords, and Teflon tapes. They are not the gold standard, they are not the rubber dam, but they could be useful to isolate partially the operative field. For example, the window dam to be used together with retraction cords, cotton rolls, and Teflon tapes allows for the contemporary cementation of multiple restorations, carefully checking the interproximal contact points and without placing and removing clamps several times, with risk of injuring the soft tissues. Differently, Teflon tapes are very useful to protect the surfaces adjacent to cementation area, creating waterproof barriers. In my opinion, however, they can be used for crown cementation with simplified cements and only for isolation as isolation aids, in the adhesive techniques. Finally, the selection of resin luting agents has to take into account the moisture content of the operative field. If it can be kept dry, total etch cements still represent the gold standard, particularly in anterior areas. Conversely, in the presence of residual humidity, self-etched cements should be preferred. Now let's move to the management of the clinical steps of cementation, particularly focusing on the challenging old ceramic materials. As we mentioned, glass ceramics, both feldspathic and lithium disilicate, have to be cemented with adhesive techniques to be strengthened and improve the mechanical properties and the longevity, and conventional cementation is not indicated at all with such materials. They have to be etched with hydrofluoric acid ranging between 5 to 9% for no more than 20 seconds and then selenized. Then the clinician can choose total or self-etching adhesion and resin cements, both light cured in case of thin and translucent ceramics, or dual cured in the presence of opaque coarse or thicker restorations. And it is worth noticing that the properties and performance of dual cured resin cements are much better if they are light activated. In this slide, we can see the clinical summary of these passages, from the conditioning of the ceramic surface to the adhesive steps of cementation with rubber dam that we have already discussed before in detail, focusing on the differences between the total and the self-etch approaches. Vice versa, as we have already noticed, zirconia is a silica-free ceramic material oxide, metal oxide, and should be cemented with conventional luting agents just like GIC or resin-modified glass ionomer cements, or with the simplified resin cements. Field isolation is not mandatory, but the control of contaminants such as blood and saliva is advisable. Before cementing zirconia, it is recommended to use both chemical and mechanical surface pretreatments. And in case of simplified adhesive cementation, coupling agents just like MDP and silane could improve the bond strength. If you choose to use translucent cubic zirconia, you can go for light curing resin cements, but don't forget that it presents reduced translucency. Consequently, it is always advisable to use light activation of dual curing cements. Briefly, to date, resin-modified glass ionomer cements still represents the first choice to cement zirconia in standard conditions. However, the tribochemical surface pretreatment and dedicated MDP-based primers can promote adhesion of restorations. So, is it possible to draw clear guidelines for the cementation of dental ceramics? It is for feldspathic materials that strictly necessitate adhesive techniques to be strengthened. It is for lithium disilicate as well, for which we will use purely adhesive or simplified techniques according to the type and thickness of restorations. However, no univocal guidelines can be drawn for zirconia, as conventional luting agents are considered the first choice, but simplified resin cements could be useful in case of insufficient retentiveness of preparations. Thus caution, zirconia is not a suitable material to cement purely adhesive restorations. And now, let's see the most practical part of this presentation. How to choose the best cement according to clinical situations and to the characteristics of the dental adhesive and of dental and restorative substrates. This is a graph showing data collected by the ADA in 2017 about the clinician's choice of dental cements. And when I first saw this, I was convinced that a bigger part of the graph referred to resin cements, but I was surprised. In the United States, and I'm pretty sure that in Europe the trend is similar, most practitioners are still using conventional cements, mainly resin-modified glass ionomer cements, so luting agents with intermediate properties between traditional and resin cements. In my opinion, this choice is coherent, as hybrid cements are very user-friendly, tolerate wet contamination and can be used without strict isolation, and are really versatile since they are suitable for both metal ceramics and zirconia. Resin-modified glass ionomer cements are particularly useful in case of subgingival margins. They do not significantly interfere with aesthetics in anterior sides, as shown by these reintervention crowns, and give good retention and easy cleansability. This is a very important point in posterior areas, as in the case of this periodontally compromised molar. Moreover, as reported by this very interesting review of the literature, They offer high survival rates with zirconia restorations and can be used in all oral regions. Here you can see a minimally invasive single crown on a maxillary central incisor and a very easy posterior restoration on an upper premolar. And furthermore, resin-modified glass ionomer cements can be successfully used to cement the implant-supported restoration even in case of zirconia abutments as shown by this challenging lateral incisor. Of course, the choice of the right cement must consider the type of support first, being teeth or implants. And as regards tooth-supported prosthesis, the type of restoration is the most important parameter to assess, whilst the abutment material is the main discriminating factor on implants. And let's start from the tooth-supported restorations. In the decisional workflow, we have to consider the type of restoration, the material, some choosing criteria, and finally the cement. And let's evaluate anterior crown first. No doubt about metal ceramic, traditional materials just like glass ionomer cements or hybrid cements are for sure the first choice. As regards composite crowns, it will be necessary to evaluate dental tissues, thickness and translucency of the restoration. On enamel, three-step resin cements are preferable, whilst we will go for a self-adhesive on dentin. With the thickness higher than 1 mm and opaque cores, dual-cure resin cements are the right choice, whereas light curing materials can be used with thinner and more translucent restorations. As to zirconia crowns, we will consider mainly the retentiveness of preparations. If retention is enough, resin-modified glass ionomer cement will be the first choice, whilst on short abutment, resin cements will be preferred. As regards lithium disilicate, once again we will assess tissue thickness and opacity according to the same criteria described for composite restoration, so that the decisional making process is almost the same. No differences as well in this process in case of short span anterior bridges, where the choosing criteria will be the same as single crowns. Moreover, the reasoning will be similar for posterior crowns, with the only differences, as you can see in the lower part of the slide, of choosing reinforced resin cements instead of aesthetic ones to better tolerate the occlusal loads. And the same selection will be useful dealing with posterior bridges, where the clinical criteria do not differ. As to veneers and additional restorations, irrespective of with restorative materials, composite, feldspathic, or lithium disilicate, the cement selection has to be carried on according to tissue, opacity, and number of restorations. The three-step aesthetic resin cements on enamel and self-adhesive on dentin, preferring dual-cure systems in case of opaque or single restorations, and light curing ones with translucence and multiple veneers, so as to extend the intraocular working time. Similar reasoning for posterior onlays, inlays, and overlays, where feldspathic ceramics are not recommended, and reinforced resin cements represent the gold standard in order to properly withstand the occlusal forces. The choosing criteria about thickness, opacity, and number of restorations are the same as previously described. As to Marian bridges, all materials can be used, even zirconia, since it is possible to create mechanical retentions on the supporting wings. And due to the fact that there is no primary retention, it is necessary to use conventional or simplified resin cements on enamel or on dentin respectively. And although the Marian bridges are preferentially used in anterior regions, it is recommended to use reinforced cements in order to resist displacing forces. And finally, the post and core restorations. If you go for cast metal posts, you will need conventional water-based luting agents for sure, whereas in case of glass and quartz fiber posts, self-adhesive resin cements will be necessary but rigorously reinforced and dual curing to withstand the occlusal dislodging forces and avoid interferences with light transmission inside the root canal. So we have discussed the selection of cements on natural teeth. Let's see now how to face the implant-supported restorations. This time, the main choosing criteria is not the type of restoration, but the abutment material. And on titanium abutments, the literature suggests the use of metal ceramic restorations, of course. And in case of single crowns, conventional cements are the first option, whereas water-based temporary luting agents can be used with bridges due to increased retentiveness and in order to make the retrievability easy. Vice versa, on zirconia abutments, we will select hybrid cements with zirconia restoration, as previously mentioned, and simplified aesthetic or reinforced resin cements with lithium disilicate crowns, respectively, in anterior and posterior areas. As regards zirconia bridges, resin-based temporary cements are usually the first choice because of sufficient retentiveness. The digital tools have made this decisional process much easier thanks to dedicated application just like this one developed by GC. You can select the substrate and restorative material. The software analyzes the clinical conditions and proposes the best product, showing in addition the clinical steps to correctly perform the cementation. And such applications are very common and user-friendly because can help clinicians in formulating the treatment plan and enhance the communication with patients as well. And now, let's try to sum up all the information we have discussed today in a few clinical, I hope, useful conclusions. Briefly, let's see the key points to achieve the best adhesion. Preserve as much enamel as possible, of course. Carefully remove all contaminated tissues before performing cementation. Keep proper moisture according to the chosen technique. Use selective acid etching with simplified or universal resin cements on enamel margins. Clean up thoroughly the dental surfaces. Periodically check, this is very important, the power and wavelength of the light curing units to be sure to give the right power to your adhesive strategies. If choosing self-etch techniques, always use MDP containing primers. And finally, vigorously blow the adhesives to completely spread them over the adhesive surfaces. And now we have all the information necessary to answer the most frequently asked questions about cementation. Today there is no universal cement for all clinical conditions. This is clear. So particularly in complex cases, it will be up to the practitioner to select the most appropriate luting agent. And the literature data are not exhaustive, and further randomized clinical trials will be useful to better understand the long-term reliability of the latest generation materials. Then, how to choose the best cementation technique for all ceramic materials? For sure, not only blindfold trusting the marketing advertisements, but carefully evaluating the presence of silica components, the retentiveness of your preparation, and the conditions of the operative field. In conclusions, research has to go on both on laboratories and clinical studies. As to date, the choice of the best cement is still based on a comprehensive understanding of all the elements contributing to cementation procedures, such as materials, patient's needs, and the expertise of the dentist. At the moment, it is clear that no material can be considered ideal and suitable for all clinical situations. Considering the constant development of innovative materials and techniques, the clinicians have to keep themselves continuously updated to choose the best cementation procedure. And finally, adhesion should be considered a powerful tool to enhance cementation, but not an irreversible prerequisite. In fact, in prosthodontics, cementations mainly mean retention and not always adhesion. In my opinion, good clinical practice should rely on expertise and evidence, and not on fashion trends of the moment or single pics posted on social networks. Then let's look at future with experience coming from tradition and good critical sense with simplified techniques based on clinical and research evidence. Well, my lecture is finished and I hope I was able to give you some information useful for your daily clinical practice, as well for a comprehensive and critical choice of dental cements. In this slide, you can see my email address, so please feel free to contact me for any further need. I would like to thank you and for your kind attention, and I will be glad to answer your questions now. Okay, now I can see your questions. I will open them. So Adrian is asking me about intraradicular post. What is your opinion on this subject? Thank you. I guess I've answered briefly to these questions. I made my PhD thesis on this topic, and I can tell you that the simplified techniques are for sure the best, being sure to have completely removed the remnants of mechanical instrumentation. So you can use self-adhesive cements, but degreasing with ethanol or the application of acid etching just to clean up the surfaces could be useful. Moreover, remember to use dual curing cements because of the interference with light transmission inside the root canal. Check the power and the wavelength of your light curing unit, and don't go for too deep posts because as much apical you are, the lower retention you will have. So usually I do not place in standard conditions, of course, from the periodontal point of view, posts deeper than 6 millimeters inside the root canal. Then Livio asks, what type of butyric agent do you use for temporary cementation? Well, mainly I use non-eugenol containing zinc oxide cements for sure. And when I need to stabilize, for example, onlays, overlays, veneers, or when I have infrared-supported restoration, usually I use resin-based temporary agents, better if clear. They are very easy to clean up and they do not interfere usually with the gingivas of the patients. Then I have a question from Simone Marini. Do you believe etching lithium disilicate restorations with 9% hydrofluoric acid for 20 seconds is incorrect? No, it is not. I've highlighted this point in one of the later slides. Usually I prefer to use 5% hydrofluoric acid, but you can use for sure, according to the literature and to manufacturers' recommendations, 5 to 9%, but for no more than 20 seconds, it's the right etching time. Then another question from Livio. For cementation of zirconia single crowns, do you use GIC or resin modified cement? Thank you. I guess I've answered this. My first choice is usually the resin modified glass ionomer cement because it presents intermediate properties, the easy handling of the resin cements, but the easy cleansability and biocompatibility of the traditional cements. So it's my first choice in standard conditions, and I go for resin cements mainly with simplified techniques if I have not retentive preparations on zircon. At the moment, I cannot see further questions. I ask if there's anything else. Well, I don't think so. So I hope to be exhaustive with my presentation. Once again, I would like to thank you for your kind attention, for being here today on Saturday, and for your challenging questions, because for sure I will use your hints to make my presentations even better. Thank you very much and goodbye.